Top Bed Talk.
With Jerison here. Today's piece is an EBPOM highlight. All this week we're focusing on EBPOM as we get ready for EBPOM Live from London, the groundbreaking perioperative medicine conference that you can attend without having to leave your bedroom. Ensure you attend EBPOM Live from London. Go now to ebpom.org and find out more.
Thank you for joining us during this session. It is my pleasure to introduce the next speaker we've been up here all day, but I don't know if you know this or not, but he's a fellow Kentuckian. So we're all from America, from Kentucky. So Mike Manning's going to talk to us about the opioid crisis that is happening in the U.S. that I think, may be starting to happen here in the UK and abroad, but definitely is a major epidemic in the United States of America. So, Mike, the title of your presentation was Can We Kick the Habit? And, when you first see it, it's like, okay, can we in the U.S., kick the habits as patients? Because you showed the overdose rate, West Virginia and Kentucky being at the top of the list, where that's our neck of the woods. But it's not about the patient, it's about us as providers, right? Can we kick our habit of giving opioids?
A lot of it is. And when we were going through this process and talking to ourselves about this, a lot of times we would hear practitioners say, well, I feel like the patient needs this. Or I really believe we should do this. Okay, well, what's the data? Right? The patient's anesthetized. They're not feeling pain. You have to be awake to feel pain. It's the nociception that you're talking about. And, I was always taught hemodynamic changes, hypertension, tachycardia with incision is light anesthesia. So let's start with the fundamentals first.
Yeah. So this is a perioperative conference, and so we talked about the continuum of care through the perioperative continuum. From my personal experience, and I know we talked when everyone's talking about methadone and something, it's not just about us in the OR, it's about through that continuum of care. And postoperatively, you may do everything great during your surgery, but postoperatively, the nurses are waking up the patients to give them more Dilaudid or hydromorphone. So is that something that, is part of this whole conversation?
It is. When we were working with the urologist to build out this care redesign, it was important. We had two anesthesiologists. Tim Miller was there with that. So we had two anesthesiologists. We had two surgeon representatives of the entire group. We had a nurse coordinator for the clinic. We had two floor nurses, and we had a pharmacist there. And I think that can't be stressed enough, that wherever a patient is going to encounter and flow through the process, you have to have 1 to 2 representatives from each step of the way, each step of that patient pathway there, and everybody has to buy into it. The stakeholders have to have a very cohesive message and buy into the system.
And one more question before Slido. You talked about moving the needle and talking about, widespread adoption of opioid-free or opioid-light. What do you think right now is the adoption rate, at least in the U.S., obviously, for opioid-free type anesthesia and analgesia?
I get the sense from talking to different people at different meetings that a lot of people are kind of doing this on their own. I think they've recognized that they've given or were giving way too much and are starting to roll that back. I don't think it's really met a label per se, but I think people are being a little more attentive. They're looking at how they practice and, why am I doing what am I doing? How did I get to this point? Yeah.
And hopefully we're going to be seeing a lot more literature coming out about some of these multimodal pain management.
Right. There's very little literature at all on opioid-free right now.
Monty, should we take some questions?
Yes, we'll take Ross Carriage's. He's getting voted up now. Michael, I never mention pain, but tell patients that after their surgery, they will feel their body celebrating that they have a new hip.
Oh my God, I love it,
or
Ross.
whatever. Please comment.
I don't even know what to say to that.
Is that going to work in your neck of the woods?
I was just going to say, how are you guys?
I want you to feel your body celebrating.
That's funny. So, but I think changing the narrative, honestly, we talk about comfort levels and not necessarily pain levels. And I think that has helped us a lot in our practice to do that.
I think we reflect on this. We went through a long period of time with the great lie of we'll take all your pain away.
Right.
Whereas I think the opening comment now is we all know it's going to hurt, which was referred to earlier. Surgery hurts. What we're going to do is make you as comfortable as possible to achieve your goals. Try not to mention the P word, and go for things like celebrating the wonderful feeling, that beautiful feeling of that new hot hip bursting with energy to try and liberate you. What's the evidence for caffeine use?
I don't know of any strong literature that supports that. We have met several patients that have come through for second cases that have reported to us they have horrible headaches and they feel miserable, and we ask them, what's going on, what medications are you on? And surprisingly, we've met a lot of patients that are big coffee drinkers. And so we kind of said, And so we would supplement with just a little IV caffeine. They feel great, they wake up, they're happy. And I wonder if that's something that we shouldn't formally look at. And, at Duke, I encourage the trainees, take a caffeine history, right? So for the patients that come in fasted, and you could go down that discussion point for a while, but, patients coming in from home have been fasted or self-fasting from 8 or 9 o'clock the night before, and a lot of them, especially the older patients, are strict about that. So they'll show up at 1, 2 in the afternoon. They haven't had anything to eat or drink, but they also are about a pot of coffee down.
Yeah.
And so...
Well, and it's funny that you say that. In our enhanced recovery program, when we first started, we started having that. We're like, we don't want to give pain medications for a headache when they had their hip worked on. And we started saying we changed our MPO status, and they could have black coffee in the morning. And so we'd tell them, drink your coffee in the morning. And then when we promoted early drinking, eating, and moving, part of that drinking part was, okay, we're going to get you some coffee, and that helped.
So I'm just going to share a comment before the next question. They're called healing sensations, not pain. Love it. You're going to have healing sensations. Are you worried about post-op delirium and ketamine use?
We haven't really seen any evidence of some post-operative delirium in our patients in the group that we are consistently using this in. But we're also avoiding midazolam in these patients. We've pretty much restricted the use of midazolam in these patients. So I wonder if in the patients with the ketamine use, and it's a low dose of ketamine and it's stopped intraoperatively, if we're not seeing some, ketamine and Versed interactions.
Do you feel like maybe, like you said, where you're cutting the use of it off? Because we noticed in our practice that if people were dosing it towards the end, we did have a little bit more post-op delirium, especially like waking up. Whereas if it was all kind of front-loaded, it wasn't a problem. Did you look at that?
Not in a formalized way.
Yeah.
And Mike, the gabapentinoids in the elderly, are you still pressing on with gabapentinoids in the older patient? Because there's been a pushback on that as well that might be driving delirium states.
Right, so we try to avoid that in patients 60 years and older.
What is the role of intraoperative remifentanil? We use a lot in the UK for maintenance and long cases. Is this a good or a bad thing?
So I think it's a thing. I think you have to be aware of that. I mean, I don't think there are absolutes in what we do. I think there's best practices. And in some cases, there is a need for remifentanil. When you don't want to do neuromuscular blockade, if you're doing some neuromonitoring and you want a patient to hold still, so I think there's a role for it. I think you just have to be aware that post-operative pain may be an issue and you may have to escalate to more aggressive multimodals or start with multimodals in that setting where you're going to go in with Remy.
The next one relates to how you achieve muscle relaxation. What do you suggest to use to help with the cramping pain post-operatively? And this also goes with what mode of reversal, which is quite fashionable to discuss that at the moment.
Right. So right now we use a lot of Sagamidex in our patients because we want that clean, absolute neuromuscular reversal. When patients complain of abdominal pain, our nurses are doing a better job about getting them up and mobilizing them, getting them to walk to the bathroom, and having that movement after lab chole seems to help quite a bit. In those patients that are just, I can't do it, we'll give just a little hint of midazolam, like a 0.5 milligram or 1 milligram based on body weight. And that's just enough to break that cramping tension and getting patients to relax. And we'll talk about that when I go to the bedside and I meet the patient, I'll tell them, this is going to feel like you've done 1,000 sit-ups. And I'll tell them, we can treat that. How many
people know what it feels like to have done 1,000?
Not that I would know, right? I've heard. I've heard it felt like 1,000 sit-ups.
Is that in a lifetime or one session?
But furthermore to that point, okay, not about the sit-ups, but The cramping, like skeletal muscle, like cramping and things like that. Any muscle relaxers, like Flexeril or anything like that? Because I know I've had people ask me about that before.
We haven't really encountered that. I mean, if you use socks, unopposed, we'll have that, but we rarely do that anymore.
Gotcha.
What do your lap chole day case patients get given to take home?
Oxycodone, about 3 days worth.
Well, why do you stick with the oxy? What we're hearing about oxy is like a designer addictive drug, and you all seem to be keen on handing it out to them.
Oxycontin and there's
oxycodone.
And they're two different, and you guys will probably know the dose the difference exactly. But Oxycontin is a much more potent form of medication, and that was what was pushed back. And you can correct me if I'm wrong on this. Back in West Virginia and Kentucky and some of the coal mining states, and got people addicted. It's highly addictive.
Very quickly.
Yeah, and so that was what people were pushing for a long time, even for the lap choles and things like that. Now I think people pushed it back a little bit.
Right, we're more Percocet.
And haven't you had some statutes in some states that now restrict, because you were, saying you can't say the whole of the USA, but there are reports of people sending people home with hundreds and hundreds of tablets, and OxyContin in particular, that then gets leaked into the community potentially.
Right.
Have you heard of the class action lawsuit against the company that made OxyContin? Yeah, and that was the problem. And I think to the next question about pain scores and things like that, what is your experience about working with surgeons and changing prescribing methods of post-op pain control and post-op opioids? Because to us, we changed everything intraoperatively and in the hospital, but surgeons were still sending home a ton of narcotics.
Well, for us, we have the surgical intern that's out on the floor that's doing this. And so educating them is important. The mid-level providers, the nurse practitioners that are on the wards, they kind of oversee practice. We brought them to the table and we're kind of clear, like, look, this is where we go. Now, what we did that I've talked to other people that I think we were kind of ahead of the curve and we didn't know it was a good thing when we were doing it. We brought a pharmacist in.
Brilliant.
Right. And so the pharmacist helped look at in-hospital opioid use to then be able to determine what will this patient most likely need going home and can advise from that. So I think if you have the access to a pharmacist, I don't think you can be stressed over. Incorporate them in your care design and get them involved in the post-operative care. Even on the floor, we're looking at the opioid use out on the floor, the timing of the duration, when the patients are using, and the cost. Sarah Cooper is helping me. She's back at Duke. She's an incredible pharmacist, and she's helping look at the cost of these opioid-free, because we're adding a lot more medications, right? And it's not as cheap as methadone. But looking at that compared to the cost savings of time we're charging patients for the recovery room time or hospital length of stay time, and translating that into, are we getting a financial benefit from it? I think we'll show that we are.
So I'm sorry I'm going to have to interrupt because we've got a slightly truncated session. Just as you leave the stage and we say thank you after you give the answer, Mike, is it time to reintroduce nitrous oxide to reduce analgesia requirements from Simon? A yes or no answer, and you can take it up with people afterwards.
No.
Top Med Talk.
Hi, it's Desiree Chappell here. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Most of our podcasts from Top Med Talk are either presentations from the EBPOM conference or they're interviews with people who attend the EBPOM conferences. Have you always wanted to attend an EBPOM conference, but you are unsure because of travel, accommodation, costs, whatever it may be? This year, are you planning to respect social distancing and avoid attending large social gatherings while minimizing travel? Do you want to attend one of the most important medical conferences of the year without having to leave your home? Go now to ebpom.org and discover EBPOM Live from London. Get all the latest and greatest information streamed live to your home, office, or bedroom as you attend the conference virtually. Submit your questions, network, and hear these talks before anyone else in the world. In light of the recent COVID-19 pandemic, attendance for this conference is at an all-time high. We only have some limited spaces available. Carbon-friendly conferencing is here. Be part of the most exciting development in medicine since the invention of the stethoscope. EBPOM.org.